So our first speaker this morning, we have Dr. Vikram Sabhaney, and he's looking at Paediatric Analgesia in the emergency department. Vic has completed his medical school education at the University of Alberta and then his residency in pediatrics at UBC, followed by his fellowship in pediatric emergency medicine at BC Children's Hospital. And he's gone on to be the director of the fellowship program since 2014. So I'd like to thank Vic and invite him up here to the stage.
Good morning, everybody, and thank you so much for having me here this morning. My name is Vic Sabhaney, and I'm one of the emergency physicians at BC Children's Hospital. I'm really excited to come and talk to you today about the assessment and management of pain, not only in the emergency department, but at home once you send these kids home. You'll see a general theme through all the pediatric presentations today. We never have any conflicts of interest to disclose. I'm looking for a conflict of interest to disclose, so if anybody wants to come find me afterwards, that would be great. Since I have no potential biases, I have nothing to mitigate. So we're going to have three main objectives through the presentation today. The first is to be familiar with tools that we can use in the emergency department to assess pain successfully. Secondly, I want to have some evidence-based strategies for managing pain using pharmacologic agents. And lastly, I want us to be able to empower caregivers to assess and manage pain at home. So this might look a little bit familiar to some of you here. Why care about pain? At some point in our lives, in all honesty, we all experience pain, whether it's through illness, procedures, disease, injury, and it's something that's part of life. However, we know that there are long-term consequences of not managing pain successfully. And a recent example came to mind. I had a 6-year-old girl who came in. She had a laceration on her finger. It was a bit of a complex one, so it needed sutures, unfortunately. But she was really anxious around medical visits and very anxious about procedures specifically. So for this 25-kilo girl, just to get the IV in, we had to give her 10 milligrams of intranasal midazolam, another 75 milligrams of ketamine, another 60 milligrams of propofol, just to repair the finger. And then she needed to come back the next day for us to take a look at the wound, and that required another 10 milligrams of midazolam. And the parents quite carefully identified that the reason she was so scared was that she used to go to the dentist's office, get papoosed down, and get dental procedures done. So obviously whatever happened to her has long-term consequences. Can you imagine being tied down, you can't move, and this is all you see? Yeah, I can understand why you're scared of procedures, absolutely. So this girl's experience made me really think about how we assess and manage pain in our emergency department and whether we could do a better job. Now, this young lady's experience is not uncommon, actually. It's well described in the literature. The paper I have here is a seminal paper, and it actually looked at infants who underwent circumcision. Infants who were circumcised without any analgesia showed far stronger pain responses when they received their immunizations as compared to those who were not immunized, or those who had circumcision with topical anesthetic, or those who were not circumcised at all. So it seems like there's something related to pain behaviors very early in life that alter how you respond to pain in the future. Another paper, this was a systematic review that looked at children who received many painful experiences in the NICU. They then looked at them from a few days later to 11 years later. And what they found is the kids who experienced more frequent painful procedures actually had changes in behavior, cortisol levels, EEG, and neuroimaging. So clearly there's some long-lasting effects from numerous painful procedures. Well, let's quickly go through one more study. This is a study where they actually got children to immerse their hands in cold, painful water baths. And they measured pain at the time. They measured the memory of pain 2 weeks later. And then they measured pain when they asked them to submerge their hand in a cold water bath for the second time. What they found was the memory of pain was the strongest predictor of how much pain this child would feel the next time they put their hand in that cold water bath. So clearly there's something going on with long-lasting effects from early pain experiences. You want to think of it essentially as an equation. If a child has recurrent pain, they have undertreated pain, and there's some individual factors, they'll develop a pain memory. And we know that this pain memory leads towards heightened pain responses, anxiety, and an increased need for analgesia. So I hope I've convinced everybody about how important it is to treat pain in young children. So the question is, how good are we at actually managing pain? This is one study of 12 pediatric emergency departments across Canada, and they look at analgesia provision amongst those with confirmed appendicitis, so a known painful condition. And what they found was that analgesia provision was quite poor. In fact, only 35% of patients received any form of analgesia in one center for appendicitis. So I want you to remember this little guy. Next time he shows up to your emergency department requiring sutures, you can thank the person who saw him before for maybe not treating his pain adequately. So we've seen the terrifying results now of pain. The question is, what are the underlying barriers to successfully treating pain in young children? This was a cross-sectional study survey done across all pediatric emergency departments, and they tried to identify barriers towards successful treatment. And there's many of them. Like, we get it. We're all busy. We have multiple competing interests. Sometimes we're not comfortable with it. We don't have resources. But one really important thing that came out of this is that a lot of us actually don't feel comfortable understanding and assessing pain in children. So that seems to be an issue, is the assessment of pain in the first place. It's shown in the last slide. Assessment is an area that we can work on. Unfortunately, we don't do a good job of documenting pain scores. We know that if a child has a pain score documented, they're much more likely to receive analgesia. However, in children, less than 50% of ED visits for painful conditions have a single pain score documented. In adults, actually, we do a lot better job, relatively speaking. And there's many barriers to this. As I was saying, we're all busy. It's hard to assess pain in kids. Families are not used to the environment. They're not used to us in the emergency department as physicians. And kids actually don't tell us about pain unless they're prompted to do so. So it would stand to reason if we could overcome some of these barriers, we would increase our assessment of pain and therefore increase our provision of analgesia as well. Every time we do an assessment, we always carefully take into account 4 of our vital signs: heart rate, rest rate, blood pressure, and temperature. However, by the end of this talk, I'm hopefully all remembering that the 5th vital sign is actually pain assessment. So now I'd like to go through a few cases together to kind of help us develop a strategy towards assessing pain in the emergency department. We have a 14-year-old female, unwell for 2 days with abdominal pain. She's got right lower quadrant tenderness, some rebound, and guarding. So we're pretty sure that she has appendicitis. Well, how can we assess this young lady's pain? The good news is, I think this is one that we probably are all pretty comfortable with, the teenager. We simply use the numerical rating scale on a scale of 0 to 10. How bad is your pain? 0 being no pain, and 10 being the worst pain you've ever felt. It's important to give word anchors with the numerical scale, but it's really easy to use. We don't have to think twice about it. And as it turns out, it was finally validated as a useful score. Earlier this year, someone actually bothered to do a systematic review of this and said, yep, it's a good tool. There are a couple limitations to the numerical rating scale. The first is it might not be as sensitive as the visual analog scale. But again, I think ease of use in the emergency department is a much more important factor than maybe having a slightly less accurate scale. In addition to that, it's not really clear what the minimum age is that you can use this scale for. Definitely, it can go down to 8 and be a very reliable tool of pain. However, it might be as good as children as young as age 6. So it's a bit unclear what the lower limit is for using this tool. Now, let's move to something we're maybe just slightly more uncomfortable with. We have a 5-year-old, monkey bars, of course. He falls, lands on his wrist, and has a swollen, tender wrist. So we're pretty sure that there's a fracture there. How can we assess pain? The issue with these younger children is we can't use the numerical rating scales. They don't have the developmental capacity to do this. They can't do what we call serialization. So instead, there's other many easy-to-use tools that are out there. This one here is called the Facey's Pain Scale Revised, and you may have seen it maybe in your own emergency department, maybe in papers. But this is a very easy scale to use, and each face corresponds with a score, 0, 2, 4, 6, 8, and 10, going from left to right. Again, it's a really easy to use score. It's well validated. The instructions actually come in multiple different languages, so there's no barrier from a use standpoint there, and it's free. So this is actually the go-to tool that we tend to use for our children between ages 4, I listed as high as 12, but usually up until 8. By the time they're 8, they tend to be able to use numbers quite nicely. Traditionally, we used to have arbitrary cutoffs as to what was no, mild, moderate, and severe pain. However, there finally was one study published that actually validated cutoff criteria. So interestingly enough, people with no pain would rate themselves as a 0 or 2, with mild pain as a 4, moderate pain as a 6, and severe pain as an 8 or 10. So we can use these cutoffs, and they're very easy to use. Now, the last case, I think, is the most difficult one to use, because how do you really assess in a minimally or nonverbal child what kind of pain they're experiencing, and how do you know if they're having less or more pain than before? It really feels like a guessing game. So the example I want to use is a 6-month-old who's come in with fever and vomiting for a couple days. The child appears well on exam, but you're worried about a urinary tract infection, so you decide to do a catheter on this child, which is totally fine. The infant's quite fussy post-catheter. How on earth are you going to assess a 6-month-old's pain? It seems like a really daunting task. So the scale that I would recommend using is something called the Flakt scale. This is a well-validated scale that can be used in children who are quite young, and I would recommend using it in anyone under age 4. It's based on 5 behaviors: facial expressions, leg movement, activity, cry, and consolability. And each of these scores can get a maximum of 2 points to a total of 10. If a child scores greater than 6, it means that they're having significant discomfort and should be treated. It probably seems a bit overwhelming, but don't forget that it's not only contingent upon you to do this, the whole team can share in the responsibility. The bedside nurse with vital sign checks can also fill out the Flakt score, so you're not going to be the sole person responsible for doing the Flakt score. I should mention that the Flakt score can also be used for developmentally delayed children who are not able to report their own pain scores. So there are really numerous opportunities where we can assess pain in the emergency department. This can start at triage, in the waiting room. They can have an assessment upon placement in a room with vital sign checks, with any interventions that may happen, and at the time of discharge. So there's numerous opportunities to gauge what is the child's pain level. And note that I've listed that there's different players who can assess the pain. It doesn't just have to be the MD. It doesn't just have to be the RN. The one person that shows up in every step along the way is the parent. And the reason is I think it's very important to engage parents in assessment and management of their own child's pain. At the end of the day, I'm not going home with the child, the parent is. There's many different ways that we can really integrate this into our workflow, and this is not just true of children, it can be true of your adult patients as well. So one of the ways that we've done it at BC Children's Hospital is we've incorporated a pain scale box into our vital signs so that the nurse can continue to track pain scores every time she does a vital sign check. In addition to that, we've incorporated it into some of our algorithms or pain management algorithms. One of our common complaints that we see is migraines, and we've developed a protocol for it. Built into the protocol, you must mandatorily measure pain at assessment, after oral treatment, and before you escalate treatment. So it's already built into the pathway. Similarly, our appendicitis pathway, which is on the EM network, also has providing analgesia built into the pathway as well. You can have signage to make your ED more friendly. So this sign here basically says to families that we encourage assessment of pain, that we want to include families in the assessment of pain, and that the emergency department can be a comfortable visit. It does not equate with pain. Other things that care providers will do is that some of our healthcare providers will wear badges or hand families placards so they can try starting to assess what their child's pain is like. One of the coolest interventions that I've seen done, and that will really offload a lot of the work from us as healthcare providers, is in Calgary at Alberta Children's Hospital. They're handing out these 2-sided bookmarks to families and showing how to use them. They teach families how to use them, and they encourage a discussion about further pain assessment and management. So at a certain point, you walk into the room and say, "How's your child doing?" The parent will say, "Oh, he has a pain score of 6. you don't even have to be assessing pain anymore. So one of the key things is as we make our EDs more friendly is we're actually offloading a lot of this pain management work to the families who are ultimately responsible for their own children. So now that we've talked about the assessment of pain and how to make our EDs more pain-friendly, let's talk a little bit about the treatment of pain. And I want you to remember 3 simple principles: use, escalate, and add. It's very easy to use, and to be honest with you, works quite well. So the first step when a patient presents with mild to moderate pain in the emergency department is to use something. There's a lot of good pediatric literature on how to treat mild to moderate pain, and there was a large systematic review published just in the last couple years. What the systematic review found was that ibuprofen outperformed acetaminophen and oral codeine, like hands down was better. It also performed equally to combination products like ibuprofen codeine combination or acetaminophen codeine in combination. More recently, a large study published showed that ibuprofen equally performed as well as oral morphine. So for me, my first choice for an oral analgesic is ibuprofen for most kids, unless a contraindication exists. So we've used, and the child still seems to be in pain. That's actually not an uncommon thing. Even though ibuprofen is the best single agent for pain, only 52% of patients who were in these studies actually achieved adequate analgesia with a single agent. Unfortunately, in the pediatric world, we don't have a lot of data about combination medications and how effective they are. So I turned to the adult literature to better understand what works well. So there's a Cochrane review that was published looking at adult patients post-wisdom tooth extraction, and what they found was combination ibuprofen and acetaminophen were far more effective than ibuprofen in isolation. When you looked at the amount of people who had adequate analgesia, 72% of those with combination products had adequate analgesia as compared to those who received ibuprofen alone. Only 50% did. And by combination products, I shouldn't mean that they're marketed as combination products. It's ibuprofen and acetaminophen is what I mean by that. I think one of the other things is if there's inadequate analgesia, is just to make sure they're on the optimum dose of the medication that they should be on as well. Now, if appropriately dosed ibuprofen and acetaminophen in combination don't adequately manage pain, then the next step is to add an oral opioid. And certainly, we've previously identified morphine as equal to ibuprofen as monotherapy, but with a lot more side effects. There was a large systematic review looking at the safety of oral opioids in children, because I think there's a lot of concern around using oral opioids. And what they found is that, yes, ibuprofen and acetaminophen are both far more safe than opioids, and that's why we use them as first and second line agents. Interestingly, what they found, though, is that if you used an oral opioid in combination with a non-opioid, it was far safer than using an opioid by itself. So what I would recommend is using Advil and Tylenol or acetaminophen, ibuprofen, and if that's not sufficient, adding an oral opioid. And you can pick whether you want oxycodone, hydromorphone, morphine. They all have liquid suspensions, and that works totally fine. Just take careful note that there's one medication that's not up there, and that's codeine. Codeine has been recommended to not be used in children under age 12, as there was a case series of deaths reported. Now, what if the pain is so severe when they come in that oral analgesics aren't going to cut it? Or use escalate add doesn't seem to work. Well, traditionally, we've always gone the IV route of providing oral or IV morphine, fentanyl, or hydromorphone. One of the big pushes that we have these days is moving towards a needleless system. Again, getting rid of some of the phobia, and then you can also deliver analgesia much more quickly. And it's been shown that intranasal fentanyl is equal in effectiveness as compared to IV morphine. So we're using actually a lot of intranasal fentanyl at 1.5 micrograms per kilogram, and this seems to work really well for our patients. So something I would advocate that a lot of people do. What we use is we buy a little product called the atomizer. I think they're about $4 or $5 a piece, and this allows you to aerosolize the fentanyl and effectively deliver it intranasally. We actually use it for midazolam as well for sedation, and it works very well. So ultimately, the child goes home to the parent, not to me. And so they're the ones who are going to be responsible for administering analgesia. We know from good outpatient studies that the maximum pain tends to persist for 48 to 72 hours post-discharge. So this child is going to need pain assessment and management at home for the next 2 to 3 days. However, we know that parents often do not provide adequate analgesia at home, and there's this phenomena of oligoanalgesia. And we think that part of this stems from the belief that medications should only be used as little as possible or only when their child is having severe pain. Therefore, it's contingent upon us as healthcare providers to provide a discharge plan at home, how to assess pain, psychological and physical strategies, safe medications, but also when to return to the emergency department. Based on limited literature, we know that the majority of parents tend to provide analgesia to their children in one of two circumstances: when their children complain enough that it bothers them, or when their children are crying. But we also know that most children actually won't volunteer that they're having pain, so there's probably a lot of undertreated pain out there in the community as well. So what I recommend to families is that they should assess their child's pain first thing in the morning, before and after they give any medications, and at bedtime. And that'll give them a better understanding of how their child is actually doing. Now, in the emergency department, I think it's really important that we use pain scales that have a numerical value attached. The reason is it'll just help us better understand the trend of how the patient is doing. However, we know that parents have no desire to use any of these pain scales at home whatsoever. They don't want to make things any more complicated than they already are. One really cool tool is the stoplight tool, and I find that it's really easy to use and very intuitive for parents, and children are very willing participants with using this tool. So what I do is I tend to refer parents to the Stoplight webpage where they can use this tool. It hasn't yet been validated, but I understand that the preliminary data looks very promising. Another tool that parents can use to help keep track of their child's pain at home is a pain diary. It better understands when their child's pain is worst, what interventions performed worked, and how it's sort of interfering with their day-to-day activities. So this is another free tool that one can download online from the About Kids website. Fortunately, the same rules of medications tend to apply at home as they do in the emergency department. I always encourage them to use ibuprofen as first line, again, assuming that there's no contraindications to using this medication. Escalate with acetaminophen if that's not sufficient, and add an oral opioid if the two combinations are not enough. Remember, avoid buying manufactured combinations, so combination Advil, oxycodone, for example, for the reason that it's too hard to titrate the two drugs successfully, and you're often limited on maxing out one medication because of the second medication there. And don't forget that 99.9% of kids are constipated, so if you don't want to make the other 0.1% constipated, maybe add a stool softener as well. In terms of resources, one of the great websites out there is the TREC website, which is a Canadian initiative to help translate the best bedside care across Canada. And they have what we call a bottom line recommendation for both presenting pain and procedural pain. So they have a beautiful 2-page summary of kind of what I've talked about today. So if you're looking for additional resources, feel free to go to the TREC website. So just to summarize, there's well-validated tools to use in the emergency department for assessing pain. I think for the majority of kids, the 0 to 10 scale is a fantastic way of doing it. For the younger children, the FACES Pain Scale Revised is another very easy thing to use. And for the nonverbal children, consider using the Flakt scale. Use the principles of use, escalate, and add. So start with ibuprofen, add acetaminophen, and if that's insufficient, add an oral opioid as long as it's not codeine. And empower parents to assess and treat their child's pain at home. They can use the Stoplight method, a pain diary, and treatment of pain is same at home as it is in the ED. Thank you very much.